talk about a few different things here. This is a 13-year-old who's very active, plays basketball, softball, doing all kinds of things, and then has this injury playing sports. I forget which one it was, playing basketball. And a lot of these injuries, you know, they think they'll remodel and they'll be fine. Closed reduction should always work. Anybody treat this as anything but a closed manipulation?
13-year-old female. So 13-year-old female.
13-year-old female.
I will do surgery. I'm just looking at that X-ray on the lateral view. It looks like there's a plastically deformed distal. There's a huge bow in there, other than the fracture. That's pre-existing or at the same time, but a 13-year-old, in my opinion, a female is to be treated as an adult.
Yeah, I think that's always the tipping point, you know, for the peds ortho people is when do they start treating them as adults or when do they refer? You know, because for some reason they don't like to plate these things. They like to just put flexi nails in, you know, extra epiphyseal. That's what they do. That's what they're trained to do. But most of these get treated closed because they say it's going to remodel. It's, you know, it's a kid. Doesn't look so bad. It's in the axis of motion. It should be okay, right?
I think something, if it was that displaced, I would fix it, but then I would like to see a post-reduction to see where she's.
Let me see if I have something like that here. Okay, so then we just talked about that. She just started having her periods. Physe's still open. She still has some growth. And we talked about all this, casting, pinning, open reduction, et cetera, et cetera, et cetera. And so these are the reduction criteria published about when you're less than 9, you're a real child and you can remodel these things, can tolerate angulation. And if you're over 9, it's less. Everything's less. And proximal radius fractures versus distal. How much can you tolerate? So that's her, healed. She was treated closed. Is it okay? Alignment okay?
So if I saw this in clinic and she presented to my clinic like this, and I would actually say it looks okay.
Yeah, I mean, she went back doing stuff. She felt okay. There was no pain, no issues. But 10 months later, she looked like that. And she wasn't okay. So what do you think's going on here?
Yeah.
Physeal arrest. Hard to predict that up front. But she got a gradual deformity, which translated to functional deformity. Not just, it looks a little different. You see her carpus is subluxing out the back a little bit. And she's got a long ulna. So decreased risk flexion, all the things you would see with an extended articular segment. She had markedly restricted rotation, which was not good for an athlete. And her DRUJ was unstable because of the asymmetry and the incongruence of the DRUJ. So now what? She's 14 something now. That's what she looks like. That's the contralateral wrist as well.
So what I would do is, well, she's symptomatic, right? DRG is unstable. She's dorsally angulated. She's going to get carpal maladaptive instability. Maladaptive. For me, it's a osteotomy incorrection possible, depending on how much height you need. Sometimes you have to do ulnar shortening. But then what I found from this type of injuries is that there's a rotational component that I can't really assess well just by looking at plain radiographs. So in my hands, I would do what's called materialize, which is you get 3D scans of both sides, and then you superimpose, for example, the left and turn it into a right. That's your template. And then you working with engineers, you could actually create guides to do osteotomies that will correct for rotation, length, alignment, and so forth. So for me, it would be materialized.
Yeah.
Is the distal ulna physis closed too?
I'm sorry?
Is the distal ulna physis, the grow plate is closed too or not?
Yeah, I mean, everything looks like it's closing now.
Okay.
You know?
Like, do you need it to do other than the correction of the radius, shortening of the ulna at the same time?
So that's always the question. Do you correct the radius and do an ulnar shortening? Because it's very, very difficult to get full length with a radial opening wedge osteotomy. I don't care what you do, whether you put in laminar spreaders or you want to stage it with an X-fix or something, it's hard to do it. So the question is, how much ulnar length is tolerable? I mean, it doesn't have to be ulnar minus. You know, a lot of people are walking around with ulnar positive variants that are normal. So to me, this is more about incongruence in the sagittal plane because of the splaying as opposed to the length. You know, the sigmoid notch is much longer than the ulnar head. So as long as you're in the same plane, you can be longer, but you're still in the notch. It's only when you're splayed out that you're becoming incongruent and blocked. So there is a limit to that. It's about 3 or 4 millimeters of shortening or lengthening that you can tolerate. But beyond that, as long as you have get rid of the tilt. If you get rid of the tilt, you can tolerate some shortening. The tilt accentuates the shortening.
Yeah. One thing also is sometimes you have to, let's say you fix the radius and your DRJ may still be unstable because she has like a styloid fracture, right? So she may have like a TFCC injury. And in order to, there's this other component called the DOB, this dorsal oblique bundle, which is part of the DIOM, which is the dorsal interosseous membrane, or distal interosseous membrane. In order to tension that, you actually have to shorten the ulna.
That is an important segment of the interosseous membrane,
Yeah.
distally. So this is what we just talked about, radial length and tilt on both. So that's the business with the sigmoid notch. Sigmoid notch is bigger than the head of the ulna. It's longer and bigger circumference and bigger in terms of length. So there is some slop in the sigmoid notch for the ulna, and that works to your advantage. So this is what we just talked about. So we talked about earlier why supination is so important and why it cannot be recovered by therapy. If there's an anatomical defect, you cannot recover that by exercise. You can't stretch out your dorsal capsule and recover it. Whereas you can recover flexion and extension by stretching out your mid-carpal joint, but you can't do it here. So if you don't have it right after the injury, you're never going to get it. And if it's unacceptable to you, and this study asking patients as patient-mediated outcome, the only thing they cared about with distal radius fractures was return of supination. Patients. So again, why do plating do better with supination than X-fix is because you get the sigmoid notch better. So a lot of times when people put X-fixes on, they lost supination because they disregarded the rotational component. They just were going for length, and that doesn't do it. So here are the options: opening, closing, plus or minus bone graft, do the ulnar shortening, and what about the DRUJ? So we talked about all this. So this was an opening wedge osteotomy and just a cancellous graft because the plate will hold it and it remodels very quickly. That's volar plating. So you talked about materialese. The cheap materialese is just using the lift-off technique. You do an osteotomy, and then you use the shape pre-contour of the plate to reconstruct the tilt. And it's not as exacting as a computer-generated, diagrams, but that costs about $5,000. And if you use the plate itself, you can correct the tilt with just the plate by putting it in parallel and bringing the plate to the bone. And it works very, very well. Not just for this particular fracture, but for malunions in general. And that's what I use. So that's what she got back. So she got back to about neutral, not really, dorsal volar 10-degree tilt, but the ulna was still long, and that was the question, is that going to be a problem? Will that be a problem? Did she need an ulnar shortening osteotomy at the same time? So that's the way she is at 2 months. She has full motion. No instability, full motion. And I saw this young woman now quite a number of times for other reasons, because she had been getting hurt and playing sports. But this is her 1 year out, lost nothing. Here she is at 8 years out. I got x-rays on her 8 years out. Ulna's still long. No symptoms, no instability, full motion. So I don't think you always have to do an ulnar shortening osteotomy. I don't think it's necessary if you get the tilt back properly and the length is not too far off. There's no magic about that. Arbitrarily, I think 3 or 4 millimeters is acceptable. Beyond that, it isn't. There she is at 8 years. So this is what we're trying to avoid, is these lunate malunions, right? Either dye punch type step-offs, Palmer translation, Bowler-Barton's type step-offs, all these types of things. And the reason you lose supination is you have rotation of the sigmoid notch component. So you can see how much rotation, malrotation there is in this axial cut of a distal radius that was treated closed. This person had 0 supination. Here's, again, sagittal and axial cuts that show you when the sigmoid notch is no longer congruent, that automatically translates to loss of supination. So once you reduce it, then you get full supination. So this just shows you in the operating room. This is a patient that had indications for operative surgery. So you see on the left, I'm examining this patient pre-op. And you'll see the full block to supination, just neutral, and then immediately post-op, nothing done on the ulnar side, just correction of the sigmoid notch deformity, full motion. I don't know why that doesn't play. Can you see if you can click on that in the box? It's not doing it. Too bad. Yeah. See, no supination, complete block on the left. And same patient after the sigmoid notch is reduced, full motion. So that's the secret. I don't even think the radial column is that important. I think it's all the medial column, it's all the lunate facet. If you get that right, patient's happy. That's it. Here's another case, different. 75-year-old, very unstable fracture. You see this radial translation of the articular facet, and very comminuted on the dorsal column. So what do you want to do with something like this? Closed treatment? They say everybody older, you can just put in a cast. Just put in a cast. That's why that's all nonsense, that literature. There has to be some guardrails around that recommendation. You just can't accept anything. What would you do with this? Tony?
I'd probably do a dorsal spanning plate. You have a very short segment distally. And obviously DC's going to confirm that, but it just looks like a very short segment. And my ability to get good fixation in the articular fragments is probably pretty limited. So I would go for that.
So this is a plating case for you? Single plate, double plate?
Probably dorsal spanning.
Okay.
Bring her out to length and proper alignment.
What do you think?
I'm going to pull out the length, see how it looks like. I will have the spanning plates available. But if I think after getting out of the lung is fixable, I may still go volar plus radial column plate. I'm worried that translation in the coronal plane.
Yeah, I mean, I like that concept of you see radial translation on the corpus on the injury films, a radial column plate that buttresses it is very good. Because volar plates really don't have enough screw fixation in the radial column, especially when it's comminuted. So that's not going to be enough to hold it alone. You could always say, yeah, I could, do a volar plate and an X-fix, or I could do a volar plate and a dorsal spanning plate, but not just a volar plate. That won't do it, probably. Any other comments?
The X-fix idea when I first, but I'd probably refer this to Nico here.
I think kind of like a P-lung fracture, right? You just reduce your X-fix and get a CT scan afterwards. That's what I would do. Get this reduced and then get a CT scan and then make a decision based on that, because if the articular surface doesn't look good, for me, I wouldn't dorsal. I don't X-fix, so I wouldn't dorsal span it. But then on top of that, I think the DRHA is going to be out. The TFCC is torn because everything is so radial. So I'll be ready to do something with the radius, and then be ready, like book extra time to potentially do something with the TFCC.
Okay. There's the post-reduction. You asked for it. How is it?
So can't see it well, so I get a CT scan.
Looks like there's coronal plane fractures because on the radial column you see two separate subchondral lines.
Well, would anybody accept this and say, let's go 2 weeks, 3 weeks, see if we hold it?
I think it's going to fall off.
DRJ is going to be unstable if you just leave it too.
Osteoporotic, very comminuted, very unstable. It's not going to stay. So the question is to the patient and the family, are you willing to accept a malunion, or do you want us to try to restore some anatomy? One or the other. So that later when the cast comes off and they see how deformed the arm is, they're not surprised. And they can accept it. If they're part of the decision-making process, they can accept it. Otherwise, they find it very difficult to accept. You didn't tell me it was going to look like this, doctor, and you have that to explain to them,
Yeah.
So I always have that little story ahead of time. And it works, too, because they don't ask any questions about it later. All right, so this is this business about the elderly. I've got a real problem with this, treating people like this, I had a patient. She was married to a Columbia professor, but she was from the UK. And she fell visiting family, and she went to see one of the registrars or one of the consultants, and they said, yeah, you need a wrist fracture, but in our system, National Health System, you're too old. You got to be treated in a cast. Told her right to her face. The only reason you're not being operated on in a case that's unstable and should be operated is because the government said it doesn't make any difference. That's what it's come to. Anyway, so you have to worry about the tilt. That's the thing I worry about the most. So this is how she was treated. What do you think about this? Ancient, archaic treatment should be banned forever? Or is it, Paul Tornetta treats every single one of his wrist fractures with an X-fix. You know that? Everyone.
Yeah. If you look at the data, right, it says it's pretty equivalent overall in the long term. So
Yeah.
I wouldn't do that, but.
Is it acceptable? The way it is.
Per the literature is acceptable because it has been reported that you can have equivalent results compared to other techniques. Is it the right thing to do in 2026? Most people, I don't think he chooses this method. Most hand surgeons chooses this method as a first choice.
So it avoided all the usual caveats. Don't over distract it. Don't get the MP stiff, et cetera, et cetera. So theoretically, it can work, and the radial styloid pin is to prevent the translation. So that's the way it looks at 2 months. Frame still on it. You really can't stay on longer than 2 months. So she had no pain, felt good. I don't know, does it look healed? 2 months, metaphyseal bone. No pain, press on it, doesn't hurt. So the fixator came off. Patient was put in a splint. 2 months later, that's how it looked. Now what?
Pain, no pain.
Terrible,
Pain and limited motion rotation.
terrible problem to have.
It also depends on what the patient's goals are. You know, is it pain? Is it motion? You know, I imagine the joint is not great. You know, so even if you do restore overall alignment, length, etc., you may still be looking at a painful joint, painful stiff joint.
This is pretty predictable, right? Based on the initial injury images, the risk that you're going to end up that shortening is pretty predictable. More commonly, it's going to end up with something like this than not, unless you do some more aggressive treatment from the beginning.
I mean, is this potential for an osteotomy and an ulnar shortening? Or just in situ plating, or what?
There's probably intra-articular malunion, right? Malunion / non-union. Intra-articular. If not even the amount of the bone subchondral, not much. I'm not sure how we're going to get this right.
Okay. Any other comments?
Yeah, I think there's different. What's her functional status?
Very little. I mean, she has very little wrist motion. Her fingers are a little stiff, swollen.
Like before the injury.
Before injury, she was independent woman.
Yeah.
You know?
There's a couple of ways to address this. So, like Uku said, for example, if the joint, I wouldn't do intra-articular osteotomies and try to make this into a perfect radius. I think the ship has sailed. If the articular surface is reasonable, you can try to go after the radius, but then I think you're going to have to bone graft it. And I don't think allograft would work it here because of her, she's probably like pre-osteoporotic. That's why this happened. It didn't really heal. So you have to add some biology. So, you know, ilicrest or
Well, what do you
that.
think really a crest graft's going to look like at same age?
Yeah, so I'm just saying, like, you can try to go that route, realign the sigmoid notch to make it, because it's oblique right now, make it straighter, and then maybe do a ulnar shortening, right? You could do that. Or if the functional status is not that high, you could kind of do a DERA, right? Just cut the distal ulna, with the caveat that you can have, it's not a perfect surgery. You could have proximal stump impingement and so forth, but then DERA might be an option for her.
Yeah, and Dara's still a reasonable salvage, especially in this situation. Okay. Now we talked about all this. Anybody go crazy and go for a wrist fusion right away, or a proximal radioscapholunate fusion, just a proximal row?
So I think if her pain is all ulnar, I think I would go more DERA. If it's pain with range of motion, I think it's very reasonable to also do a wrist fusion or some sort of fusion, and then plus or minus the ulnar side, because it looks really long.
Okay. So that's what we just kept watching it, you know.
Yeah.
Sometimes these people go away.
Yeah.
or die. But she didn't. She just keeps coming back, and that's the way it looks. Deformity is worse. You think it's as bad as you can get, it finally stops, but it actually keeps going.
Let's watch another year. Let's see how worse it gets.
Keeps settling.
Eventually.
She's creating a new sigmoid notch halfway down the ulna now.
Yeah.
So what do you want to do for her? She does want something. She's unhappy now. Unhappy.
I think it's going to be really hard.
She's basically a happy person who is now unhappy. That's what it looks like.
For me, it would be at this point, I'll probably do wrist fusion and a DERA.
Yeah,
Go for it.
Go for it.
Yeah.
I would do
Okay.
that.
My happy patients are-
Strap on and go for it.
I think the opportunity to correct her and give her more functional wrist with motion assailed that's not going to be possible.
Long time ago.
Long
So
time.
more the fusion route for you, Tony.
I think so.
Go fusion.
Yeah. Go fusion. Use the ulnar head as your bone graft to help with the fusion,
Okay.
or even just like a limited fusion. Like you can do like radiocarpal.
What if she said, I have to have some motion in my wrist? I have to.
You want to do arthroplasty?
Or I'll go crazy if I don't have that.
You're going to do arthroplasty?
No,
If she,
that's too far.
so she wants motion.
No, I mean, she's willing to do anything that we think is reasonable, basically.
For me, I think like a lot of my happiest patients are the wrist fusion patients.
Yeah, that's true.
Yeah.
That's
and
true.
so if I would say if you want one surgery that could potentially make you happy as long as you sacrifice some motion or all of motion would be wrist fusion
Okay.
there.
So that's what it looks like when you get down and dirty. It's a real pseudo.
Yeah.
It's a real pseudo. Wasn't over distracted, never opened, never infected, just didn't heal. You think they all heal. Radial metaphysis, unbelievable. But they don't all heal. So that's what I decided to do. I'm going for the non-union. I'm going to go fix it. I don't give up easily. Michael taught me that. He said, don't give up. So I put a spanning plate on and resected the distal ulna to try to balance the wrist. So that's what it looks like.
Did you
Getting
use
it
the
lined
distal?
up, getting a spanner across.
Did you use the distal ulna as bone graft?
Yeah.
Yeah.
That's what it looks like now. She doesn't have a lot of skin on top there. You can read the serial numbers in the plate. But she's straight now, and she's happier with that. That's what it looks like. And she does, she has reconstituted a little bit of a joint. And I mean, there is a joint there, because most of the fracture was extra-articular.
Mm-hmm.
So it wasn't like the joint was destroyed. That would have pushed you to fusion. So this is a spanner with a Dara. And with the Daras, I don't always take out the styloid. It's unnecessary. It's not anywhere near impingement. And kept that on
How long you kept that spanning plate?
about 4 months. And then I took it off. And that's what she has. It's healed, 40-40, 60-60. And she's happy. Thank you.